Seated. Over to Dr. Guruprasad,
Uh,
sir.
Thank you, Dr. Srinivas, both for the opportunity and for the generous introduction. So my topic is the TASS versus endophthalmitis, how to differentiate and how to manage. No financial disclosures relevant to this topic. So TASS basically is a non-infectious, when a non-infectious substance enters the anti-segment, it causes an acute post-operative inflammatory reaction called TASS, toxic anterior segment syndrome. And this is, can be blinding, can be very dangerous because it causes toxic endothelial cell destruction, and that is a syndrome called TECD syndrome. So post-operative endophthalmitis, on the other hand, is defined as an inflammation of the inner course of the eye resulting from intraocular colonization by infectious agents. This is also potentially blinding. More than half the cases are caused by Staphylococcus epidermidis, and because the inflammation in the eye can be disastrous, and because each can mimic the other initially, at least, a timely diagnosis and management are crucial in both, and the management of each is different, and that is why we have to discuss this topic. So here is the famous list, the list of differentiating factors, but I would like to draw your attention to the three marked there with the arrows: the timing of occurrence of the inflammation, the corneal edema, which is different in both, and the vitreous on B scan. So timing of presentation, TAS usually occurs within 24 to 36 hours of surgery. Post-operative endophthalmitis usually around the 5th day of the surgery. Coming to the corneal edema, it is diffuse in TAS with minimal congestion or no congestion sometimes. Limbus to limbus is the typical description given, and patchy in post-operative endophthalmitis, but this congestion here will be severe. And finally, the vitreous on the B scan especially. Vitreous is not involved in TAS, but can show membranous vit echoes and choroidal thickening in post-operative endophthalmitis. So we already mentioned about the definition: non-infectious substance entering the anti-segment and inducing a toxic damage to the intraocular tissues. What are these? Apart from, I'm just going to list out the things that we normally use in cataract surgery. But apart from that, the concentration of intracameral antibiotics that we usually tend to give at the end of surgery also is important. And medications contain preservatives. So I think that can also lead to this postoperative inflammation. Any retained cortex or prolonged surgery, anything that can or has the potential to cause intraocular inflammation, we have to keep in mind. So even full surgery, it could be PC rent after which we just heard about, the retained cortex, and you can see here on this, in the slide on the left, and the arrow pointing towards the linen fiber that can be left behind, which is literally a time bomb. It need not cause immediate intraocular inflammation, but can lead to post-operative inflammation any time during the course of maybe months or years. And this is something that we have to watch. So these are all the drugs, no proprietary interest or financial interest in any of these. These are all the drugs that we commonly use in cataract surgery: lignocaine, intracamerally, adrenaline, pilocarpine, Viscoat, I'm sorry using the brand name, chondroitin sulfate, moxifloxacin we use several other things. We use drapes, we use gloves, we use IOLs, and some batches of IOLs can cause problems. This is just an example. So the glove powder, blood on the instruments, which is dried, which is sterile, no doubt, but the blood elements can cause inflammation because of their reactionary nature. The blood within the cannulas, which are left behind, not thoroughly washed, and dried and desiccated viscoelastic on the surface of cannulated instruments can also result in postoperative inflammation. So these are all the reasons because of which postoperative inflammation can result in the condition called TAS. Blocked cannulas in the set is something that we should never use. We should just discard it if it is blocked. The nurse is trying to reopen the block by pushing forcibly, which should never be done, because we should understand that the standard flow in a CSSD, when a contaminated device is given to the CSSD department, they clean it, rinse it, dry it, pack it, disinfect it, and then keep it for monitoring and storage. The most important step in all this is the cleaning. So if you cannot clean it, you cannot sterilize it. That is the thing, that norm that you should maintain in your mind. So there are some updates on the safety committees, about safety committees which can help prevent TASS and POE. Basically, it's a platform. The committee is either the VRSI or the IIRSI, the Indian Intraocular Lens Implants Society, each of which we have to report in case of any inflammation caused by a particular batch of drug or consumable. TASS is amenable for therapy, but not to be taken lightly either. The response to steroids is excellent, but it can cause permanent damage to the endothelium. Prevention should be aimed at do a root cause analysis, inform the safety committee, follow the safety committee's advisories, make corrections from our own experience and from the colleagues, and train the OT and CSST staff. Post-operative endophthalmitis, I'll try to finish within a short time. Spectrum of presentation is very wide and depends on the virulence of the organism, size of the inoculum, host resistance, time till consultation, and all these factors in varying degrees can result in endophthalmitis of varying severity. So why should we differentiate? The fulminant type can destroy vision within a day, the ones caused by the gram-negative bacilli, for example. The less acute type can go unnoticed by the patient for a very long time, and if he doesn't examine his eye, doesn't check his vision on his own, he will probably end up in a blind eye. A delayed follow-up visit can be disastrous, and every hour counts, according to me, even if the patient is landing up in a hospital after midnight. There are several instances when we have operated on endophthalmitis patients after midnight as well. So coming briefly to what causes endophthalmitis. Patient factors, CSST factors, surgical factors, and breach in OT adequate. These are the four, I would like to classify the causes as these four. And patient factors, as you all know, is basically based on the personal hygiene of the patient and also certain nidus of infection, like the molluscum contagiosum or nodules or the sebaceous cysts, not to forget conjunctivitis and ectocystitis. So importance of torchlight examination cannot be overemphasized. It's very important. CSST factors is when we overlook the indicators or overload the instrument or overload the sterilizing equipment when we have a lot of surgeries. Surgical factors, prolonged surgery I already mentioned. Poorly sutured wound or a gaping wound is something that we have to keep in mind as a potential cause for endophthalmitis. MICS is something, and MDCS is something which I'll just come to. If I think many of us know already what MDCS stands for. It stands for this. This is MDCS. So we should remember that there is some appreciation for fast surgery, but definitely not hurried surgery. It is not a bakery where it is nice to see how these bakers work, but at the same time, surgery is something which we should give respect to the eye. So high-speed surgery is something which we should avoid, and there is a certain number of surgeries that we should keep in our mind. We should not be trying to do more surgery just because we have an overload. I think we'll skip this slide. OT etiquette is a subject which is close to my heart, and I think we should, it's a topic which we can discuss for more than 30-40 minutes. I think we'll not go into the details, but all I want to say is that every step should be properly adhered to. Like the AIOS guidelines are there, change gloves after every case, change the gown after every 3 to 5 cases, and post-operative follow for eventful intraocular surgery, not just eventful, even normal uneventful surgeries also we should follow up in a way that is safe for the surgeon, for the surgeon and the patient too. See the patient on the same evening, again the next day, again on the third day. This is sometimes not practicable, and therefore we have devised a system where we teach the patient about self-assessment of vision every day. We call it the SAVE, which literally saves the patient from endophthalmitis. So lid edema, congestion, pain, and loss of vision are the 4 symptoms and signs that we explain to the patient that might occur, and loss of vision is something that we have to emphasize on, and this loss of vision has to be reported to the counselor or to the surgeon immediately if such an event happens. The best way to diagnose endophthalmitis early is to practice SAVE. So this is what I was talking about, teaching the patient, the resident is teaching the patient about, patient's attendant about finger counting. Just finger counting is enough, no need to read the Snellen's chart in detail. So protocol in a case of increased reaction, to summarize, intensify antibiotic and steroid drops, decompress. Decompression is something that is done like this on the slit lamp itself, under topical anesthesia. The scleral lip of the wound is pressed with a needle, sterile needle, and immediately the cornea becomes clear. We can have some view of what is happening behind, and that I think gives a lot of information about the nature of inflammation. And also provides for microbiological testing and ocular sampling. So I think this is very important. And one thing I would like to share with you is that I never do a biopsy, vitreous biopsy. I've always done a vitrectomy and then sent the material for culture. I would like the opinion of the panelists later. So anterior chamber lavage is something which is underutilized by many anterior segment surgeons. I think this is very easy and easy to do. At the same time, you can get some sample for culture as well.
In the interest of the time, can we just, please?
So intravitreal injection is something that we should all know. So summary is, in one slide I would like to summarize. Timing of inflammation is first day versus fifth day in TASS versus endophthalmitis. Corneal haze is diffuse in TASS, patchy in endophthalmitis. Vitreous affection is important to note. Decompression is a technique which should all follow. Patient really feels better after decompression, and we can also diagnose the posterior segment better. Everyone must know the ABCD of intravitreal injection. I wish I had the time to tell you what ABCD means. Loss of fundus glow is something that warrants urgent referral for vitrectomy. And the SAVE exercise, which I just mentioned, is something that is very, very valuable for prevention of endophthalmitis. Thank you very much.
Thank you, sir. Thank you very much for that beautiful talk on how to differentiate